All right, I'm going to talk real quickly about the 5 places where most of the money gets left on the table for PDPM. The first place and the place we have probably the most control is making sure we get ADL documentation. So whatever software you use, whether it be point of care or care tracker or any of those things, you want to make sure that you have good documentation submission, and you need to be monitoring this real time. So your building needs to have a process for making sure things are get documented. Every system has something like what I'm showing you here on the screen, where it will show you where there's charting omissions. In this case, nothing's been charted by my day shift, my night shift, or my evening. Of course, that's a big problem because I'm not going to capture a good ADL score. The other aspect of your ADL scores is making sure that you capture documentation across all 3 shifts. It's imperative to get that picture of the patient around the clock, not just during the day when they're most awake, when they haven't had their pain meds, when they're not tired from therapy. The daytime, they're probably going to be more independent. And then in the evenings and night, as they're tired and medications take effect, you're probably going to see your increased dependencies. So if you have weak charting going on in the evening and night, you're definitely leaving money on the table. The second place is not understanding the non-therapy ancillaries. And these primarily relate with physician diagnosis. The challenge here is doing such a deep dive into the medical record that you're going to pick up on things that got dropped in the hospital and didn't come over in the transfer because they weren't in the hospital for, say, fibromyalgia. But with the NTA points, if you can capture these different diagnoses, then you can capture extra NTA points, which is the place where you're going to actually bring up your money the most, second only to ADL scores. But again, you have to be the person looking at this patient globally, because just like the hospital physicians are looking at acute issue, the nursing home physicians are looking at the overall management of their health and not necessarily the deep dive into everything. So they're still thinking in that myopic kind of vision of acute issues, what I need to do to keep this patient healthy enough to get home. So they'll acknowledge the fibromyalgia, but it won't occur to them to add that to the full list of diagnoses because they may not be actively planning or working on it at this point. But it's important as the MDS nurse that you do try to capture this and get it in place. So the next piece is guiding the staff. If you're not guiding the staff on what to assess and document, you're going to be losing money. And here again, you have your ADL charting, but you can also do things such as setting up physician orders that will guide the nurses to chart, say, on pain levels throughout the day or cognition, or you can potentially set up an order that is a skilled charting order. There we go. And so in this case, having an order that'll show up and remind them what to focus on and chart on can actually be a really good thing. But it requires that you stop and you think about what needs to be charted on so you can capture the things you've identified. So instead of saying here that the resident on skilled services for physical therapy, which is a very big generalization, non-skilled services for pain management, skilled education for diabetes management, insulin administration, education, nutritional requirements, initial education. And you may also go into the functional ambulation, strengthening, training. I mean, all this sounds great, right? It looks like real nursey talk, but basically, you want to really be telling your nurses to focus on specific things, assess and document patient's ability to ambulate in room, assess and document patient retention of diabetes. So you can get very specific, and this will actually support what you're doing as far as the skilled care that you're providing. So there's a couple of ways to approach that with the system. But regardless of how you get it to them, you've got to guide the staff on what you need in that chart so that you can capture it on the assessment reference date. Next thing is you really, really have to make sure to do all the things I just talked about. You have got to deeply look at the system, and you have to review all the documents. And in our case, this is e-documents. These would be all the documents that came scanned from the hospital. And that would include, notes from dialysis. In this case, I've got a dialysis form in here that I could take a look at and review and see how that's going, capture some of those NTA points. My hospital records, the hospital H&P, of course, but you're also going to want to look at the hospital medication records and the hospital therapy records. All of those things suggest potential diagnoses and potential things that you need to be looking for that could be NTAs. And also the hospital pre-admit orders. You want to make sure you review those because sometimes things carry over or are dropped off there that are very significant. And so you're going to want to make sure you review everything. So however your system gets that in front of you, whether it's a physical chart plus hybrid system where some things are in the computer, or if all things are scanned in the computer, which is ideal, you can go through it and really do that deep dive and know what's going on with that patient, what documentation is there, but more importantly, what is not there. Because you're going to see disconnects. You're going to see things like gabapentin, but no appropriate diagnosis to explain why they're on the gabapentin. And it might be that they have neuropathies, but then you might want to find out a little bit deeper diagnosis, what kind of neuropathies are they having, because that's going to affect their ability to self-care at home. So all of this leads up into what you need to get charted so you can support your skilled service and grab those NT points and not have them taken away. And the very last thing is to not do a full diagnosis recap with the providers. Now, this is scary for a lot of clinicians because they're not comfortable going to a physician. And indeed, some physicians aren't appreciative of when you go to them asking them these questions. If that's the case, then this may be a discussion for your administration, but your doctors have to work with you. And they should see themselves as educators as well. And if you're suggesting things that aren't appropriate diagnoses, then they should take that on to themselves. But as a skilled nurse assessor, you do pick up on things and you are able to connect the dots because you have much more time, not a lot, but you have much more time in comparison to a nurse practitioner to actually pull together all the pieces and come to some conclusions that may help you gather in the NTA points. And I've talked about NTA points quite a bit. You really need to know that list of NTA items backwards and forwards. It can't be something you have to go reference. You really need to learn those. And that's the only way you're going to be able to pick up and focus in on those things that can help you with the game that we call PDPM.